To provide care to everyone on the basis of need is a privilege. It is a matter of social justice. It is what you, the public and patients, have come to expect. It is absolutely right. I've been on the BMA Central Consultants Committee for 10 years. I wanted to stay on because this year is going to be the most important year in the history of the NHS since 1948. We have come to expect our National Health Service free at the point of need, delivering care according to the needs of the individual, not their ability to pay, and a comprehensive service that is going to be funded through national taxation. On the 1st of April 2013, our National Health Service in England was abolished by the Health and Social Care Act 2012. Our health service became a national health business, and most of our clinical services in hospitals are now subject to competitive tender. Because of that act, our National Health Service became a business. It was opened up to national competition law and through our membership of the European Union to European competition law. That is a major change. Services have to be tendered. Services have to be provided by a qualified provider, not necessarily somebody who's been running the service for years, that has established referral practice, that has developed and grown the trust and confidence of the local population and of patients, has developed its expertise, has established contacts with the local general practitioners. No, a qualified provider. And under Clause 75 of the Health and Social Care Act 2012, the commissioners must remain within budget. So what is reasonable now in law is that you're within budget, you have a qualified provider. You must consider the needs of the service, the development of the service, the choice of patients and so on. But once you've considered those things, you must still provide through a qualified provider and remain within budget. It's easy to consider things as a matter of law, but once you've considered those things, you can lay them aside. Now, you may think that it is bad enough that our services are being marketized or privatized. But what happens when those otherwise profitable services become unprofitable? Look what happened when a whole hospital was taken over in Hitchinbrook. Look at what happened locally with edicts and what has happened with various community-based services, for example, provided by Virgin. Are those private providers, many of them large American corporations, required to continue those services once they become unprofitable and the contracts have lapsed? Where do those patients go? What happens to them? Essentially, they are repatriated to the National Health Service. but a lot can be lost in the meantime from those services for our patients. You will be aware that Mr. Hunt has imposed a contract on junior doctors. Last year, he was going to impose a contract on consultants in pursuance of this idea that we must have a 7-day service. If pushed, he can't precisely define what he means by that. But I can tell you, we do have a 7-day NHS, providing emergency and urgent care throughout the week. When he talks about a 7-day service, it's not exactly clear what he means. But if he really meant exactly the same services throughout a 7-day period, including elective services, we would need more beds, more hospitals, more nurses, more resources, more diagnostics. What Mr. Hunt is doing for the junior doctors, and if he succeeds, I have little doubt it will apply to consultants, nurses, and ancillary workers, is to impose this contract and to spread the work of our junior doctors from 5 days through to 7 days within a fixed financial envelope. Not getting more doctors, not paying them more, not resourcing the workforce more, but by spreading it out. I don't understand his mathematics, but 5 plus 0 does not equal 7. And what he would do, because of the way our hospitals work, which are very busy during the week, is to create holes in the rota during the working week in order to provide services at weekends. He has set a terrible precedent for public health workers. And I'm very glad to see that the National Union of Teachers is standing by the doctors on this point. He is imposing a contract. And if you look at the contract, if you look at the detail, not only is he imposing the contract, but within the terms of that contract, it says in clause 22, aptly described by Private Eye as catch 22, that the terms and conditions of that contract might be changed according to the needs of the organisation and the NHS. I'm not aware that any other contract for public service workers has such a clause. So not only is he imposing the contract on junior doctors and wants to impose it on consultants, but he has a catch-22 clause which would then bind the individual as a matter of contract, which the individuals will sign to allow their terms and conditions to be changed at the quote-unquote absolute discretion of the employers. So bind yourself in contract to an imposed contract that you, the individual, can't change. I wonder what that's going to mean for future negotiations with the Secretary of State. And if it's imposed on junior doctors, it'll be imposed on consultants, doubtless general practitioners. And then the concern is they will go for the nurses and go for the ancillary workers. And I think it is a disgrace at the moment that within the National Health Service we do, as a matter of fact, have 0 hours contracts. At the moment, we are talking about a workforce, a highly intelligent, motivated, keen, energetic, imaginative workforce, dedicated to the care of patients, that has been thoroughly demoralised. And as a result of that, we are seeing holes in the rota, vacancies. The Office of National Statistics tells us that there are overall a 7% vacancy rate for doctors, 10% for nurses. How can we allow that situation to arise when the national figure for vacancy rates is 2.7? Why should doctors have a 3 times greater vacancy rate than the national average, nurses almost 4 times? Why should we have over 10,000 vacancies for nurses, 10% vacancy rate, in part 17% vacancy rate in certain London hospitals, and a 7% vacancy rate for doctors? That is a manifestation of the demoralisation of the workforce. In 2015, 52% of junior doctors who had completed their foundation years, 1 and 2, said that they did not want to go on to further training for hospital medicine and for general practice. The number of people applying for general practice is only slightly greater than the number of vacancies. How have we allowed this to happen? And why do we believe some of the statistics and views that have been put out by that NHS nightmarish health secretary? We are told we can't afford the National Health Service. We are told that we have an ageing population, that people are living longer. Since 1948, the average age or expected life expectancy for men has increased by about 18 years and women 20 years. But that has not translated into an increased dependency. In fact, the dependency period, the time in months at the end of your life when you have increased healthcare needs, has fallen per capita. The actual amount of money that has been spent on daycare, home care, has fallen in the last few years. As a matter of fact, we are not expending more of our resources on the elderly. And it is quite wrong to say that those over 65 are not still contributing to the national healthcare economy. It has been estimated that they contribute over £40 billion annually. But let me point you to another statistic. There are something like 1.4 million informal carers in this country. Either people who are not being paid for the care of their relatives, including the elderly and those with learning disability, or who are paid an insufficient amount. Nobody knows quite how much they contribute financially, in kind. The estimates have gone up. £49 billion, £76 billion. But when I asked an executive from Age Concern, he was of the view, and I agree with him, that that figure is almost certainly in excess of the £110 billion that we pay for our NHS? And are those people, the informal carers, being supported? But things are moving on very rapidly. Our NHS is being privatised. Our doctors and nurses are being demoralised. They are leaving. And whatever you think about the recent strikes, and there was a tremendous amount of public feeling for the junior doctors. Come the summer, the 3rd of August, you may be in a situation where there is a shortage of doctors, an actual shortage of doctors who are not fulfilling their roles in the hospital. And that is going to be a very serious situation indeed. And many hospitals have said that they will impose the new contract and further demoralise the staff. So we have to stand up for our National Health Service. And why is it that on the 5th of July 1948, shortly after the war, that saw the devastation of so many European cities, the destruction of our industries, periods of rationing, when mothers could still die in childbirth, when children and young people could still die of infectious diseases, diphtheria, polio, pneumonia, tuberculosis. Why is it that then the British people had the courage to embark on then an untested social endeavour which has been the envy of the world? And why is it when the Commonwealth Fund, centred in America, regards us as having the finest healthcare service in the world, that we, the British people, cannot stand up, knowing what our health service has meant for over 65 years, and say we do not support it? We cannot pay for it. It is too much. No, it is not. It is for me a privilege to have worked as a consultant for over 20 years in this health service. It is a privilege to be able to practice medicine for the benefits of my patients according to their clinical need. And I hope that the British people who have lived with our health service, have relied upon our health service, have expected our health service to continue, will have the courage to say we must maintain this important, this essential, and this socially necessary service for the benefit of the British people and all of our patients. Thank you.